Module 7, the child with a genitourinary disorder. In infants and children, the emptying of the bladder of urine is a reflex action. At birth, the infant only will void about 15 mLs and can void as many as 20 times a day. Between the ages of 2 and 3, the child is unable to hold their urine, or they are able to hold their urine, and they learn to urinate voluntarily. They start gaining control of those sphincters. Bladder capacity will increase with age. The female urethra is shorter than the male, which we know that, which increases their risk for UTIs. The kidneys are located lower in the thorax and the abdomen than they are in the adults. And there's less fat cushion and location, which increases the risk of trauma to the kidneys. The average urine output will vary by age, fluid intake, and kidney health. Kidneys reach their full size and function by their adolescent years. Urinary tract infections are fairly common in the diaper age, ages 2 to 6, and the sexually active female adolescent. We know that it's more common in females than males, except during the first 4 months of life. It is caused by many different bacteria, the most common being E. coli from the intestinal tract. That female urethra is shorter and straighter than the male, so again, it's more easily contaminated with feces. And that inflammation can extend not only into the bladder, but also the ureters and the kidneys. These clients develop fever, irritability, vomiting, foul-smelling urine, poor feeding, weight loss, abdominal pain, urgency, and increased urination. Occasionally, there will be little or no fever. If the client is toilet trained, we may see incontinence or bedwetting. With acute pyelonephritis, we have an abrupt onset and a high fever for 1 or 2 days. We diagnose with that urinalysis, which may be the clean catch UA, and then we send it for microscopic examination, possible culture, and in some cases, a sterile specimen will be required. With a simple UTI, we can give an anti-infective for 7 to 14 days. With acute pyelonephritis, this may require hospitalization with IV antibiotics and encouragement of fluids. These kids need to continue their antibiotics for full course. We may need to do a renal and bladder ultrasound to assess for possible structural defects if they have recurrent infections. Question: true or false? UTIs are more commonly seen in the adolescent males than in females. And this is false. So with acute post-streptococcal glomerulonephritis, this appears to be a condition that is an inflammatory reaction to a specific bacteria, which is that group A beta hemolytic streptococcus. There is an antigen-antibody reaction that causes a response that injures and blocks the glomeruli and permits red blood cells and protein to escape into the urine. This happens most during 5 to 12 years of age and twice as often in boys. It's really similar to the nephrotic syndrome, which we'll talk about shortly. Prognosis is usually excellent, but it can progress to chronic nephritis. These kids have presenting symptoms that appear 1 to 3 weeks after a streptococcal infection. Their urine might be grossly bloody or a smoky tea or cola-colored or bloody urine, edema, hypertension, which appears in 50% to 90% of the clients, and a high temp of 103 to 104 initially that will then decrease to about 100 degrees. These clients may have slight headache, lethargy, and vomiting. They may have oliguria, hematuria, and proteinuria on the UA. BUN, serum creatinine level, and ESR are all usually elevated. We may see headache, drowsiness, seizures, and vomiting. Again, oliguria, hematuria, proteinuria, and cardiopulmonary congestion might also be seen. So it's very important to limit activities until the clinical manifestations subside, which may take 2 to 4 weeks. Antibiotics might be given. Antihypertensives or diuretics might be given. The diet's not generally going to be restricted, but we may limit extra salt intake. Complications will be treated symptomatically. Nursing care may include bed rest, contact precautions when allowed out of bed. These kids must not become fatigued. We have to do I&O, and intake restrictions will be based on their output. Monitor blood pressure and do urine dipstick tests for protein in blood. If the condition persists for more than a year, we consider this more of a chronic issue. The nephrotic system. There are several different types of nephrosis that are identified as the syndrome. We may see the idiopathic nephrotic symptom, which is minimal change nephrotic syndrome, which is the most common in children. Early characteristics will include edema and proteinuria. It has an insidious onset with remissions and exacerbations. Recovery rate is generally good, but the cause is unknown. It is most commonly seen in children under the age of 6. These kids have a presenting symptom of edema around the eyes and the face in the morning that then shifts to the abdomen, lower extremities, and ankles. We see anasarca or massive edema develop. Respiratory difficulty. Again, edema will shift when the child changes position. We may see loss of appetite, fatigue, irritability, malnutrition, and they're susceptible to infection with repeat acute respiratory conditions common. We diagnose through lab findings. Excuse me. In the urine samples, we have marked proteinuria. Hematuria is usually not present. In blood samples, we see hyperlipidemia, low blood serum protein, and albumin levels. With treatment, it's a long process of remissions and recurrences. So we give them corticosteroid therapy, daily urine testing and loop diuretics, immunosuppressant therapy, and a general diet that appeals to the child that is low in salt and high in protein. Possible changes will be done if what we're doing is not working or complications occur. So this slide just shows a comparison between some of the assessments we see with the glomerulonephritis and the nephrotic syndrome, as does the next slide. So question, true or false? A presenting symptom for acute post-streptococcal glomerulonephritis is edema that moves depending on the position of the client. And this is false. Cryptorchidism. This is where one or both of the testes don't descend into the scrotum. These testes should descend into the scrotum shortly before or soon after birth. But with cryptorchidism, one or both do not descend. And if cryptorchidism is diagnosed, usually they do descend by the age of 1. These testes are, excuse me, they're usually normal in size, but the cause of the undescending testes is not clearly understood. If both testes remain undescended, sterility can occur. There is also an increased risk for testicular cancer. It will require surgical correction when the child is 1 to 2 years old, which is called the orchiopexy. And prognosis is pretty good with this surgical procedure. With hypospadias or epispadias, this is where the urethra is in the wrong place. With the hypo, the urethra is on the underside of the penis instead of at the tip, and it can actually affect the male's ability to urinate while standing up. With the epispadias, the urethra is going to be on the top of the penis. It does require surgical repair, but can be done as an outpatient. Circumcision should be avoided until after the repair because the foreskin might be used for tissue for the actual repair. And if they have this defect, it may actually mean they have other defects that also require repair. And now for the post-test.